So this is a typical CT scan of a patient with pancreatitis with this all gray area is the necrosis. And it has been said that few other afflictions facing humans require the degree of flexibility as is required from clinicians in the treatment of patients with acute pancreatitis. And that is the reason why I wish to discuss with you. So its incidence is variable. It varies from 5 to 80 per 100,000 population per year. What we need to understand about pancreatitis is a very complex disease. So when you see this, this is a sort of schematic representation. When you have pancreatitis, there is edema, there is collections, and there is necrosis. These are the local things which happen with pancreatitis. This leads to systemic inflammatory response syndrome or SIRS, sepsis, and septicemia as the next level of affection, which may lead to hypotension, respiratory failure, and renal failure. And this is the spectrum of acute pancreatitis from local to systemic. And what it leads to is morbidity, mortality, prolonged hospital stay, and increasing costs for management of the patient. So that's the way the patients of acute pancreatitis, and we may see them at any of the stages. So when you look at pancreatitis, fortunately for us, majority are of mild disposition. The disease is self-limiting and patients may or may not need admission, and if they are admitted, they get discharged quickly. The 15% have severe disease, which may lead to infected necrosis or organ failure. And this is the one we are worried about because this is potentially life-threatening. So let's see what the clinical scenario is, what you would see in your practice. You may have a patient with gallstone disease. You may have patients with recurrent episodes of a typical pain, which I'll describe, or patients with known chronic pancreatitis with acute pain. The diagnosis of acute pancreatitis is clinical and laboratory. We don't need anything else. Epigastric pain with radiation to back, associated with vomiting. And when you do, in a clinical scenario, a serum amylase and lipase, they are elevated more than 3 times the lab normal. And if you have this scenario, the diagnosis is acute pancreatitis. 2 myths I want to clear. There is no point doing serial amylase levels once it is raised, because it has no value to tell us whether the disease is improving or not. The second thing is the level of amylase is no indication for severity. Please, most people think that very high amylase is very severe disease. No, there is no correlation. And we have seen people serially repeating amylase, which is unnecessary cost for the patient and has no relevance. The only thing you can do at this stage is do a erect chest X-ray to see for air under diaphragm, because sometimes peritonitis or severe acute peritonitis can present with pain abdomen like that, and an ultrasound to rule out any other cause of pain. If all those are normal, or ultrasound can show you gallbladder stone disease, that will confirm. So this is one of the messages I want to give about diagnosis of acute pancreatitis. The other important thing about acute pancreatitis is the timing. Now, everything is about timing in acute pancreatitis. So let's see what all things are related to timing. One is general thing we do about in acute pancreatitis is immediately ask for a CT scan. Now, it is very important to understand the time of CT scan, and I'll talk about this a little bit. Indiscriminate use of CT scan is detrimental for the patient and increases cost. It is important to early triage the patients and initiate treatment, and their timing is very important. The early you diagnose, the better the triaging and initial management, and has an impact on outcome. And finally, when to do any intervention or surgical intervention depends on timing. So remember, timing is very critical in acute pancreatitis. So this is the clinical pathway in acute pancreatitis. You need to have a diagnosis and use diagnostic tests judiciously. Triage the patient, high risk, critical, goes to ICU and monitoring. And then you have initial management of fluid, organ support, nutrition support, antibiotics, and you have to decide when to do intervention in this. This, in a nutshell, is how the patient's clinical pathway will progress. Now the key question, when to order a CT scan? And it's a matter of debate, and we always see multiple CT scans, and CT scans are done for patients with suspected acute pancreatitis. When there is a doubt in diagnosis, CT scan is useful because you need to rule out other causes of pain or down. Patients with severe pancreatitis based on the Apache score or Ranson score, if it is severe, then they need a CT scan. If there is no improvement in clinical condition of a patient diagnosed as acute pancreatitis beyond 3 days, it merits evaluation by a CT scan. If the diagnosis is acute pancreatitis, on day 1, doing a CT scan is of no use because neither will it tell the extent of damage nor will it help in the diagnosis of acute pancreatitis. And if patient is diagnosed with acute pancreatitis and patient is improving, there is no need to do a CT scan in such patients because it is probably mild pancreatitis and patient is improved. The usual problem happens is CT scans are done. Then on 5th day, patient is not doing well. Now you want to see the extent of damage. Patient has already had a CT scan and everyone is worried about now repeating a test. Patient is worried, increased costs because of repeated CT scan and radiation. So it is important to understand. So rule of thumb, diagnose case of acute pancreatitis without any doubt. In the first 72 hours, there is no need to do a CT scan. Okay. The second important problem is antibiotics. When to use? Again, indiscriminate. Moment diagnosis of acute pancreatitis, we use antibiotics. Antibiotics should only be used in severe pancreatitis where the incidence of infected pancreatic necrosis is high. So if you diagnose by various criteria severe pancreatitis, they merit antibiotics. If there is organ dysfunction with sepsis, they merit antibiotics. And pancreatitis in second week of where the incidence of infection and infected necrosis is high, they merit antibiotics. So our policy is mild pancreatitis, no antibiotics. Severe pancreatitis with documented necrosis, then we usually use imipenem with celastic combination, and they should not be used for more than 2 weeks. Usually this is a hospitalized setting. The other important thing in pancreatitis is a lot of departments are involved in acute pancreatitis. You may be admitted in emergency, a person sees an emergency. The radiologist is involved in diagnosis, a medical gastroenterologist, physician, a GI surgeon. And if you consider this as a patient, this poor man, everyone should be pulling in a different direction. So what you need is a close coordination with all the departments which are working in a well-oiled fashion to make sure a well laid out path is made for this patient and a smooth oiled machine with all these people because they'll all be required in management of this patient. So what we have at Sakra is a pancreatitis core working group. We have surgical gastroenterology, medical gastroenterology, emergency department, intensive care, radiology, and then we need help of nutritionists, nephrology. What it does is we have laid down protocols how to manage. It becomes more cost effective. No unnecessary treatments are done. And the team works in close coordination so that the best treatment is allocated to the patient, and the right timing. I told you about timing of intervention, timing of CT, and all that can be discussed and done. Just to quickly highlight one patient and tell you how complexity of decision making is there in acute pancreatitis. A young man came with acute pancreatitis. This is an old case, admitted to emergency. According to these criteria, it was acute severe pancreatitis. He was admitted to ICU, IV fluids, antibiotics. He had invasive ventilation was done for this patient. So he was a sick patient with severe pancreatitis, had required ICU admission and ventilation. Now look at the CT scan. Now all these gray areas indicate necrosis, and only this enhanced area is the pancreas. So it is severe necrotizing pancreatitis. Now this patient, we decided we will manage with what we call as a step-up approach, wherein catheters are placed under radiology guidance. So you can see these bright tubes, which are catheters which are placed in this collection, and we placed from the right side and from the left side, and multiple tubes are placed. What it does is it drains all the pus, and the patient starts feeling better. So this was done and managed from day 26 to 40. Patient improved, was taken off the ventilator. He was then eventually discharged with drains coming out. He was afebrile, tolerating oral feed, and he was stable. So you can see such a severe patient with pancreatitis, without any surgery, with radiological drainage, we were able to send home. But that's not the end of the story. At home, after a couple of days, he came to the OPD with fever and pain. And the CT scan at that time, these were the tubes which we had shown. So it is there, and you can see this. There is a collection there still with air pockets. That means there is having ongoing collection and undrained collection. So we have to do something about it. Since so many days, this patient had what we call a minimal invasive retroperitoneal pancreatic necrosis, and I'll tell you what it is. Following which he underwent, this is what we found after that, doing that. I'll tell you what that procedure is. And eventually on day 68,
at Samsung. I think they did a marvelous job.
On day 68, we did a video assisted retroperitoneal debridement. I'll tell you what that is. And eventually he was discharged with drains. So what we do in minimal invasive retroperitoneoscopy is, from the placed drain, that percutaneous drain, we put in a trocar, which we use to put in a telescope. Then we make other ports, and under vision, we drain out the pus and all the necrosis. And from that place, we put these drains. So basically, no incision, small holes, and we drain out under vision. That may not be always successful because the thick necrosis may not be able to remove by that method. So then we do a video assisted retroperitoneal debridement. So we go in from this by a small incision, as you can see in this picture, and we remove this necrosis, as you can see with this, under video guidance. And then we all clear that up and then leave a small drainage tube. So at the end of it, what happens is, these are the drainage tube. This patient has no big incision and he's able to go home. He has some pancreatic fluid drainage, which remains there for about 3 weeks or so. And then the fistula closes. All the tubes have been removed, and you can see small incision of video assisted retroperitoneal debridement. No big incision, which we used to have in the previous times. And this patient, though he took about 2.5 months to recover, but is absolutely well and completely recovered. So you can see that how the impact of this is in the recovery of this patient. And this is the CT scan. If you see, everything is resolved. There is no collection and no necrosis at all. So this is one example. And just I want to complete that why we do surgery. When there is infection in the necrosis and there is sepsis or some other complications or so. So generally, surgery is put off till such time that this is absolutely essential. So you know what I want you to take as a message is there are things which have changed in management of severe pancreatitis. Surgery is not the answer. We have learned these are the changing paradigms. We have learned that any intervention should be delayed as long as possible. So critical care management, supportive management, and good early management is critical. Only surgical intervention or any other intervention should be avoided till about a month. The second thing we have learned is a step-up approach. That means catheter drainage, endoscopic drainage, and finally surgical drainage, and that too by a minimal invasive approach. So these are the changing paradigms in treatment of severe pancreatitis, and it has made a great impact in the outcome of patients where the mortality initially used to be very high, and now it is less than 10% mortality. It is there still, but overall mortality is less than 10%, which is a great thing from 30 to 50% mortality in earlier times. So from my takeaway messages for acute pancreatitis is suspect, make an early diagnosis, make an assessment which is mild or severe, triage the patient, and ensure that admission is in ICU and critical care is taken care of. Multidisciplinary approach is important. Delay surgical intervention till 3 to 4 weeks, and a step-up approach and minimal invasive approach is the key. So I hope you take these messages and understand what entails the treatment of patients with acute pancreatitis.